So I have a few goals for learning, and these are to acquire some tips to manage difficult geriatric fractures. And I particularly would like to convince you that the original 4AO principles of fracture care that have been around for over 50 years are applicable to geriatric care as well. So not all the fractures are easy, and we will see and have seen with some of these cases non-unions, failed locking plates. We certainly have a class unto itself, the dialysis patient, which we see in abundance at my center. We are the catchment center for all dialysis patients. And multiple low-energy fractures in the same patient is a problem that we see. And of course, the patient who is terminal. So some of these are very challenging cases like this one. For non-unions in the elderly, these are fairly common, and they're often due to non-operative care. These must be preoperatively planned carefully. You should anticipate a higher blood loss with a non-union, and it may require an osteotomy. Remember, it's important to correct the deformity if you want to have a successful outcome. Use a locking plate or a nail, and just don't forget the metabolic bone issues. Some non-unions will heal with metabolic bone measures, such as repletion of their vitamin D stores, or using PTH. Here's a case of a non-union. This patient was sent to me after 11 months in a sling. She's tried to heal. She's got callus. She is very obese, and she was not healing. So she was treated with a locking plate, no bone graft, and she heals in 6 months. So this patient was trying to make bone. There's nothing wrong with her ability to make bone. It was just an unstable situation. With a failed locking plate, you really need to determine the cause of the failure. This is critical because if you don't determine that, you will repeat the same mistake that the first time entailed. So was the fracture really reduced? And I think this is the most common cause for non-union. Also bad osteoporosis or vitamin D deficiency. And in some cases, the wrong implant was used. We've certainly seen that presented here by several surgeons. So make an excellent preoperative plan. I would encourage you with these cases to make tracings, print the x-rays if you're digital, make tracings, and really plan the case well. So here's a case, and this originally was a proximal humerus plate that was coming along well until the patient fell backwards down a flight of stairs. He was intoxicated and pulled his plate off, and it failed just like the pictures that you see that are presented in the principles course of how a locking plate fails. It fails as a unit. And this is just revised with a nail with a spiral blade, and he goes on and heals this tremendously well within 6 months. So this is a salvage for this. I think to put another locking plate on would be the exact same problem. Multiple low-energy fractures, I would recommend these be treated aggressively, and you need strong fixation so you can get early mobilization of the patient. You want to fix their lower extremities all, and you may need to stage the care, and in some cases the patient will end up being non-weight bearing. So in this case, this woman was shopping for a new home, and she was walking around in the new home and missed one step and fell forward. She broke her wrist and both of her distal femurs. So I guess she didn't buy that house. But here she is. We have at my center only one set for each. We did not have two sets. So the simple one I fixed with a angle blade plate. This for me is 40 minutes of surgery. It's a very easy procedure and is great for the simple pattern. The more complex pattern, we used a locking plate, and this, you could argue the plates would be longer, but this turned out quite well. Both sides were fixed, same anesthetic, and this is a nice fixation and enabled the patient to be gotten up and mobilized. For dialysis patients, these patients have the worst osteoporosis. In most cases, you want to think that they will not heal the fracture. So if you're going to use a technique that requires a lot of healing on the patient's part, this is not going to work in many cases. They have many medical problems. They need immediate mobilization. surgery is safest right after they've had their dialysis. And you should consider having both your geriatrician and the renal specialist assist you with these cases. Their wounds heal very slowly, so I use Prolene suture. You should use nylon or Prolene. I would not use staples on these because the wounds heal too slow. We typically will leave them in at least 4 to 5 weeks, some cases 8 weeks, until the wound has healed. And after hip fracture, the average survival that's published with a dialysis patient is 289 days. So these are not long-term patients. You really need to think of this as a short-term fix that can mobilize the patient. In most cases, they do need to sit up for dialysis. It's easier that way, so you want to get them at least sitting up. The terminal cancer patient with a fracture, we as physicians are not great at predicting how much time is left, but I think a realistic estimate of the tumor burden on the patient and their other problems might help you decide what time is left and then what treatment to select. Usually a team discussion is helpful here with the oncologist, the geriatrician, and the family. The best pain control is sometimes a surgical procedure to stabilize the unstable fracture. Try and keep the surgical time short, keep the blood loss low if possible, and then these patients are at the end of their life in many cases. You want to discharge them to a hospice setting. The patients actually will live longer in hospice than they will in acute care. Here's 5 tips to help your practice with your geriatric patients. Tip number 1, as I said, you really want to preoperatively plan this surgery that you do on the geriatric patient. In the past, these cases have been relegated to the junior surgeons, and the outcomes are often suboptimal. If you plan the case out and really think it through, I think you'll have better outcomes. Number 2, you want to position the patient well. Positioning the patient on the table, including the draping, will often result in success or failure of your procedure. So if you don't position the patient well, you may end up with a rather difficult situation during the surgery. Also, the patient needs to be padded carefully such that the patient's skin is protected so they don't get a pressure sore during surgery. Is the room large enough? This is often something we need to think of. If you're bringing a C-arm in and you have 2 tables of equipment, the room needs to be big enough to accommodate your surgery. And I think if you have only a small room available, it may need to be moved to a larger room, or you may need to delay until you get the right facilities. Here's how I set up a hip pinning on a fracture table. This is the post with the arrow here, and I like to see that the femoral neck is absolutely parallel to the floor or perpendicular to the post, and this makes it very easy for me to shoot the guide wire in on the first pass. It's not always possible, but in many cases you can do this, and this makes life easier, in my opinion. For X-ray considerations, we all know that having an X-ray machine or a technician that doesn't know what they're doing is going to cause you trouble. So you want to make sure that you get the X-ray machine set up, the machine works, get it ready before you start the surgery. In general, moving the machine is better than moving the patient. So here's a way that I do the proximal humerus. This one, the patient is placed in a supine position, bumped up about 25 degrees with a sandbag, and she's on a radiolucent table. And by moving the C-arm over top, we have one view, and then here's the other view, and you get the orthogonal views by moving the machine like that. When you want to think about overall principles to guide your care, I would refer you back to the 4 AO principles that have been with us, I think, for about 50 years. Fracture reduction to restore anatomy. Stability by fixation or splinting, preserving the blood supply, and early and safe mobilization of the limb and patient. And these are really sort of the guiding principles that we've presented at this course as an overall guidance to your care. And it's amazing that these were developed so many years ago and they're still so completely applicable today. Preservation of the blood supply. Try to use your old incision if there's an old incision present. Get good exposure. Meticulous hemostasis, you don't want to bleed these patients a lot. This helps to keep them alive, so take your time enough to make sure that you're not cutting major vessels and bleeding the patient a lot. Use appropriate retraction, use good lighting, and try to avoid periosteal stripping. Now, in many cases, this is minimally invasive surgery, but think this through, and it's not just about speed, but I think careful attention to detail with these patients. Stripping with any of these types of instruments, if you strip the periosteum or strip the fascia, it's bad. This will cause you more trouble, so I'd recommend you not use them. Stability by fixation or splinting, that's what we've talked about the whole course. Norbert just gave excellent talk on augmentation, and use it if needed so that you get a stable situation so the patient can weight bear immediately. Fracture reduction, I tend to like indirect reductions with these. There's all sorts of different techniques for this. You're an experienced group, and I'm sure you have many ideas. I'll show you just a little tip that I have, and this is a patient who is still in varus alignment, under traction. You see there's still a little bit of displacement or dislocation on this picture. So I've pointed my pointer there. That's not an instrument in the skin. We haven't made an incision yet. So this patient has plenty of traction. It's an old lady on the table. So with a little bit of manipulative reduction, pushing first front to back to reduce the displacement, and then pushing to push it out of varus, what we end up getting is one that is now back in proper alignment on both views. And I have done nothing else but manipulate this, and I have not started the surgery yet. So I do this first, and this will now make it an easy surgery. So if this is how you get the reduction, and under traction with the setup, this will stay. It'll stay long enough for you to fix the fracture. So it's just a little thing. Again, just a manipulative reduction, and then here it is. This is literally the same patient, same time, and the varus is gone. And so we've seen a number of cases presented where the varus persists, and I think just a little bit of effort on your part like this will reward you with a much easier case. You find the guide wire then goes in the right place, and the case goes smoothly, and it won't cut out. Now, we have clamps like this, and this clamp has been around since at least the early 19th or early 20th century. This is a Lohmann clamp, and I'm sure you all have seen this sort of clamp. I know these were used even during the First World War because I've seen pictures of surgeons using them in the First World War. So these are destructive to the soft tissues. They crush the tissue. They are effective at reduction, but I would encourage you not to use them. Now, this is a Verbrugge, and this is one that actually I had made for me in 1990, and it's a clamp that is reversed, and it's actually the way it should have been made to begin with. But even it crushes tissue, albeit in a smaller arc. And then this tissue from the locking large set works the best to hold the plate to the bone. It's the push-pull tool, and this is my favorite. It really doesn't traumatize the soft tissue. It can go through a little incision and works quite nicely. Early and safe mobilization of the limb in patient is an important feature. We've mentioned this many times. Leaving old patients in bed is a death sentence in many cases, and we want to mobilize the patient. So in this case, a periprosthetic fracture using a hook plate, good fixation up top, down below. Very old lady. This woman is 96 years old. She gets up and walks right away. I used the cable only as a reduction tool in this instance because it was a difficult reduction. So in this instance, the patient gets up and walks, and she lives. And this woman is still alive today, and she's in her late 90s now. But amazingly, with this big hunk of metal in here, she still has gone through this quite fine. Immediate mobilization, the patient survives. So whatever you need to do to get the patient to move, I would encourage you to do this. This is our unit, and this is the patient getting up and walking right away. We usually don't use braces, but this particular fellow has a brace on. And this helps to reduce the likelihood of them getting pneumonia and delirium to get them up and moving. Again, if you've taken away their glasses and hearing aids and they're laying in bed, all they see is what the ceiling looks like, okay? And this will drive anyone crazy. And if the patient has a little cognitive dysfunction, they will get delirium. It's much better to see this, see the pretty therapist and the nice hallway, and they'll be much more entertained. And finally, remember their metabolic health. We've stressed this during the course. Cornel Sieber has pointed out to you to think of malnutrition and sarcopenia. A lot of times these patients will have low albumins, and this does correlate with higher mortality. We've stressed the vitamin D level, parathyroid hormone level, and calcium level. If you're not sure, just treat it. You really want to avoid that malnutrition and osteomalacia in the elderly patient because, again, this will cause them to have bad outcomes. They won't heal, and they will die. So thanks for your attention.